Hello everyone, welcome to MBBS classes. Myself Dr. Hanifa. Today in this video I'll be talking on complications of chronic otitis media. Complications of chronic otitis media are most commonly seen in the eticoenteral type of CSOM due to the presence of cholestoma and the granulation tissue. The complications, they are divided into two parts. The first is the extracranial complications, or otherwise also called as intratemporal complications, and the next complication is the intracranial complications. In this video, we'll be talking on the extracranial complications. The intracranial complications will be discussed in another video. Let us begin with the extracranial complications. The most common extracranial complication is the mastoiditis, which could be chronic or collagen mastoiditis. Different types of subperiosteal abscess, examples being the postauricular abscess, Bisol's abscess, Lux abscess, and the zygomatic abscess. The third important extracranial complication is petrositis, the others being facial nerve paralysis and the labyrinthine fistula. Let us just have a look on the intracranial complications. The intracranial complications are extradural abscess, sigmoid sinus thrombosis, meningitis, brain abscess, which could be temporal or cerebellar abscess. Next abscess seen is the subdural, and the last but not the least is the otitic hydrocephalus. So this is a diagram of the skull showing a schematic diagram of the skull showing the different locations of abscess. If you see here, this is the dura, the abscess. Outside the dura is the extradural abscess. This is the abscess in the cerebrum. This is the brain abscess. This is the abscess, subdural abscess. An abscess over the zygoma, near the zygoma is the zygomatic abscess. If we see, this is the sigmoid sinus. So this is a case of sigmoid sinus thrombosis, an abscess developing along the mastoid tip. This is the Bisol's abscess, and this is the location of the cerebellar abscess. Complications of the chronic otitis media, they occur through the different routes of spreads. So the route of spread, it could be through the bone, via the vascular structures, and third via the neural structures. When the disease spreads to the bone, the usual mechanism is due to the bone destruction and the erosions which occurs as a result of osteitis, cholestoma, and the granulation tissue. Sometimes the disease can spread also through the preformed bony pathways. When the disease spreads by the vascular structures, it is usually by the retrograde thrombophlebitis to the venous sinuses. Now let us see the different directions of the spread of the disease. So if you see here, this is a diagram of the tympanic cavity. Let us just refresh our anatomy of the tympanic cavity. This is the tympanic membrane. These are the three ossicles, malleus, incus, and stapes. This is the promontory. Just above the stapes runs the facial nerve. This is the location for the lateral semicircular canal. This is the opening of the adductus, which connects the epitympanum with the mastoid. So when the disease is present in the mesotympanum, when it goes into the hypotympanum, then it can involve the jugular bulb and the jugular fossa. A disease of the mesotympanum, if it tracks anteriorly to the protympanum, from there it can track along the internal carotid artery and the eustachian tube. In cases when the disease it extends in the superior direction or the cephalic direction, then it can involve the adductus ad antrum. Sometimes the diseases can also invade the accessory bony ear cells located at the zygomatic root, styloid process, and the occipital bone. Sometimes the disease spreads to the preform pathways. So what are the preform pathways? These are the natural pathways. Some of these are from the round and the oval window, it can spread into the internal auditory meatus. If there is a dehiscence of the thin bone over the jugular bulb, in cases of dehiscence of the tympanic tegmen tympani, or in cases of the dehiscence of the suture lines of the temporal bone and the bony facial canal, then the disease can spread from the one place to another. Sometimes the preform pathways are created iatrogenically during the surgeries. in cases like stapedectomy, mastodectomy with the exposed dura. So this is a diagram of the inside view of the skull. Sometimes the disease of the mastoid bone can involve the petrous bone and can produce different clinical symptoms. So if you see here, this is the location of the petrous bone. It is a pyramidal type of bone. This is the petrous apex where there is a depression for the trigeminal ganglion. That is the fifth nerve ganglion. Just near the petrous apex lies the nerve root for the sixth nerve, that is the abducen nerve. In the petrous bone, the three borders of the petrous bone, they are related to the three venous sinuses. Superiorly is the superficial petrosal sinus, inferiorly is the inferior petrosal sinus, posteriorly is the location for the sigmoid sinus. So when the disease involves the petrous apex and the canal, which is the canal for the sixth facial nerve, then it presents as the Grady-Negro syndrome. Sometimes when the disease involves the superficial petrosal sinus, then from the superficial petrosal sinus, this is the location of the superficial petrosal sinus, it can propagate anteriorly to the area of the cavernous sinus. This is a location for the cavernous sinus. Sometimes the disease of the superficial petrosal sinus can extend posteriorly and involve the sigmoid sinus and the transverse sinus. The second mode of spread of the disease is spread along the vasculature. This is the area of the mastoid bone. It is so centrally located in the temporal bone that it may involve the sigmoid sinus and the jugular bulb. So when there is an integrate spread of infection, it may involve the internal jugular vein. In cases of the retrograde spread from the sigmoid sinus, this is the location for the sigmoid sinus. The disease can travel back to the transverse sinus and the torcular. Infection can spread to the posterior fossa dura when the emissary veins along the petrous ridge are involved. Temporal lobe may also be involved by the retrograde spread along the venous channels. So this is how the disease it spreads along the vasculature. Facial nerve is one nerve which is at risk in cases of the chronic otitis media with cholesteatoma, especially in cases with the developmental dehiscence along the bony facial canal. Sometimes the bony erosions by the cholesteatoma can also cause the facial nerve injury. Now let us see the epidemiology of the complications. It is seen that around 80% of the extracranial complications and around 70% of the intracranial complications, they occur in children younger than 20 years. There are certain risk factors which increases the rate of complications. The factors which are responsible or which are the factors which are associated are the inadequate health education and the limited access to the health care, low socioeconomic status of the patient because of which they are not able to avail the health care. It is seen that the most common extracranial complications due to the chronic otitis media is post-auricular abscess, and the most common intracranial complication is the meningitis. Now let us discuss the individual extracranial complications one by one. The first one is the mastoiditis. So mastoiditis is the inflammation of the mastoid ear cell system. In cases of chronic otitis media, there will be the inflammation in the mastoid region, and due to this inflammation and cholesteatoma, it leads to the blockage of the adytus. So what happens in the mastoid ear cells, when the collected fluid it becomes purulent, there will be exacerbation of the mucosal edema and there will be venous stasis. The result is that it is seen that there is increased osteoclastic activity which causes the decalcification of the bony septa between the mastoid ear cells, leading to the development of coalescent mastoiditis. So this is how the coalescent mastoiditis occurs in chronic otitis media. So how do they present? A patient of mastoiditis will complain of pain behind the ear in presence of persistent ear discharge. There will be associated fever and malaise. When we examine the patient, there will be presence of erythema and edema over the mastoid. Moreover, the typical position is unilateral protuberant ear. That means the ear will be protruded outside and downward, and there will be tenderness over the mastoid region. The next extracranial complications of chronic otitis media is the subperiosteal abscess. So here the pus collects below the periosteum of the cranial bones. The different types of subperiosteal abscess being the postauricular abscess, otherwise also called as lateral mastoid subperiosteal abscess. From the name itself, it suggests that the abscess is collected behind the ear or behind the pinna. The other abscess being the Bezold's abscess, Lux abscess, Cityli's abscess, zygomatic root abscess, and very rarely a condition called Pott's puffy tumor. So if you see here in this diagram, this is the skull bone. The abscess which is collected outside the cranial bones is the subperiosteal abscess. So this is basically, if we see here, just below the cranial bone, there is an abscess. That this is the extradural abscess. Sometimes in very rare conditions, this extradural abscess can present as the subperiosteal abscess by erosion of the intervening cranial bones, and when the extradural abscess is present as a subperiosteal abscess, it is called as Pott's puffy tumor, which is a very rare condition. This postauricular abscess, it is the most common complication of the mastoiditis. Here the pus collects over the superficial cortex of the mastoid. So how do they present? They present as the protuberant auricle. As in small children, only the upper part of the mastoid is involved. The mastoid tip is not involved. So what happens, as this is the area for the mastoid tip and this is the area for the upper part of the mastoid. So in small children, as only the upper part is involved, there will be collection of the pus only in the upper part and the pinna will be pushed downward. When we examine, there will be fluctuation and tenderness, and sometimes when this postauricular abscess it bursts through the skin, it presents as postauricular fistula, as can be seen in this picture. So how the disease from the mastoid it becomes postauricular abscess. So this is a temporal bone lateral surface. If you see here, we can see here the cribriform area, the sieve-like structures on the lateral cortex of the mastoid. This cribriform appearance is due to the mastoid emissary veins which connects the inside of the cortex with the outer wall. So what happens is that there is a direct spread of infection from the mastoid to the subperiosteal space due to the bony destruction or by the phlebitis or the periphlebitis of the mastoid emissary veins passing through this area. Since in young children, these open channels they persist, and this is very much common in the young children. And as this is the mastoid tip, this mastoid tip is not developed. This is the area only which is developed in the young children. So the postauricular abscess is seen in the upper part of the mastoid. Next abscess is the Bezold's abscess. It occurs when the coalescent mastoiditis, it involves the mastoid tip, that to the inner surface. Infection spreads via the phlebitis and the periphlebitis of the veins. So in what type of mastoids we get Bezold's abscess? So definitely Bezold's abscess is seen in those patients only with the well-developed mastoid tip, with the large tip cells, and those having very thin inner wall of the mastoid tip. So the age group where we get the Bezold's abscess is not the young children, it is the older children with the pneumatized mastoid tip, and it can be also seen in the adults due to the chronic mastoiditis and cholesteatoma. So when a person is presenting with the Bezold's abscess, how do we know? There will be swelling and pain in the infraauricular region, that means below the pinna, and sometimes the swelling can spread along the sternocleidomastoid. So the patient will present with the swelling in the upper part of the neck just below the sternocleidomastoid. So sometimes in differential diagnosis we have to rule out upper cervical lymphadenopathy, and sometimes it can mimic infected branchial cyst in young children. Next abscess is the zygomatic or the temporal root abscess. So when the disease of the mastoid it spreads to the zygomatic air cells, it can present as preauricular swelling. Moreover, sometimes it can also lead to malocclusion. The reason of the malocclusion is that if you see here, this is the zygoma. This is the area for the mandibular fossa where the condyle of the mandible is situated. So a swelling in the front part of the glenoid fossa will definitely hamper the movement of the jaw. The treatment is antibiotics and the incision and drainage followed by mastodectomy. The other abscess sometimes seen are the Lux abscess, which is also called the meatal abscess. It develops when the pus breaks through the bony wall which is situated between the mastoid antrum and the external bony canal. So, if in cases of the meatal abscess, there will be a swelling which is situated in the deeper part of the bony external auditory canal meatus. The last abscess sometimes which can be seen is the Citylis abscess. Citylis abscess is an abscess which is present behind the mastoid, but it is different from the postauricular abscess because the location of the abscess is more towards the occipital bone. It is more posterior than the postauricular abscess. Facial paralysis is another extracranial complication of the chronic otitis media. It can occur when the cholesteatoma, it causes extensive erosion of the horizontal part of the facial canal. So the horizontal part is at risk in cases of chronic otitis media with cholesteatoma. Another reason for development of facial paralysis is the pressure on the nerves along with the edema which is associated with the inflammatory changes. The onset of the facial paralysis in cases of chronic otitis media with cholesteatoma is always insidious and it is slowly progressive. Petrositis is the intratemporal complications of the chronic otitis media. It is not that much common. The reason is that usually the petrous apex is sclerotic. The pneumatization is present in only 30% of the temporal bones. So, as if you remember, the pneumatization of the petrous apex, it occurs by different cell tracts. Let us just see one by one the different cell tracts. It could be the supralabyrinthine tract, retrolabyrinthine tract, that is the behind the labyrinth, infralabyrinthine tract, and the anterior labyrinthine tract. So, if the pneumatization occurs of the petrous bone through any of these tracts, then they are at risk of developing petrositis. So just this is a CT scan axial view showing this is the mastoid region. This is the area for the petrous apex. So in the CT scan we can see that this is a well pneumatized petrous apex. So in cases of these type of well pneumatized petrous apex, they are at risk of developing petrositis. So let us see again the relation of the petrous apex to the fifth and the sixth cranial nerve. If you see here, this is the area for the petrous apex. Here in the just behind the petrous apex lies the area for the trigeminal ganglion. Here is the location for the sixth cranial nerve. So in any cases of the petrositis or any extradural abscess in the petrous apex will involve fifth and the sixth cranial nerve. So petrositis is basically mastoiditis that occurs in the petrous apex. The route of spread is via the different ear cell tracts. Most commonly, sometimes it could be by the hematogenous spread. So now let us see the clinical presentation of petrositis. Petrositis should always be suspected if a patient is having an ipsilateral retrobulbar pain or a deep-seated ear pain in the presence of chronic otitis media. Secondly, sometimes they can present as Grady-Negro syndrome, which is a triad of the retrobulbar pain, abducens palsy, and suppurative otorrhea. This retrobulbar pain is usually due to the local dural involvement or it is due to the involvement of the Meckel's cave and the trigeminal sensory ganglion which is due to the anatomical association with the petrous apex. Abducens nerve palsy, again it occurs because near the petrous apex the sixth nerve it passes through the Dorello's canal. Sometimes the Horner syndrome can be seen in petrositis due to the involvement of sympathetic nerves which is present around the petrous portion of the internal carotid artery. So a very strong clinical suspicion is needed to rule out petrositis. The last extracranial complication which could be seen is the labyrinthine fistula. So labyrinthine fistula, it represents the erosion of the endochondral bone which is present over the semicircular canal by the colostoma. The most common semicircular canal which is affected in cases of colostoma is the lateral semicircular canal. They present as vertigo or the giddiness. The reason of giddiness in cases of labyrinthine fistula is that due to the loss of the protective bony covering of the semicircular canal, sometimes due to the pressure or the mass effect of the colostoma or the granulation tissue, it causes the motion of the underlying endosteum and the underlying perilymph. So it results in the vestibular symptoms. Another Tullio's phenomena can sometimes be seen in the labyrinthine fistula, which is the presence of vertigo and the ossiculopsia on exposure to the loud noise and the pressure changes. The diagnostic test which is done is the fistula test, which is evaluated with the help of the pneumatic otoscope. In this video, we have discussed only the extracranial complications. The investigations and the management of the complications will be discussed in the next video. Thank you for watching this video.